I said that I would try and make this short, and of course I went over my time limit on this video. So I'll try and continue on, and we will wrap up because I think I'm at the end of what I wanted to talk about. So we just went through those 6 dimensions, and again, these are things that you need to assess in order to place them in the correct treatment setting. So just a review, is there a need for detox? Are they withdrawing? Do they need uh, um, medicated assisted withdrawal? So do they need medication for the withdrawal process, or are they withdrawing on their own? Is there any physical complications or symptoms or issues that need to be assessed? Are there any psychological or mental health issues that need to be addressed or assessed? What is their stage of change? Where are they in treatment? Are you going to send them to long-term treatment and they don't even want to be in short-term treatment? The likelihood of success there is slim. And then, of course, what is their history with treatment? Have they been to treatment before? Have they been through the different levels of care? And now you know that you need to automatically send them to a higher level of care because they haven't proven successful with the lower levels of care. We always want to start out at the lower level of care and move forward to the higher level of care. It's not appropriate for you to immediately send someone to a higher level of care without having them experience the lower level of care. That's usually your first step, unless of course somehow, some way they are, well, I honestly can't even think of a situation, so we'll get to that now. And then of course, do they need a living environment that supports recovery and sobriety after their treatment? So do they need to go to a sober living facility or a sober house? Do they need to move away from people, places, and things that they were previously involved with and in? And so that would be a referral from you to help them get into a new environment if that's necessary. Okay, so down here, so reflecting a continuum of care. So if you see here, we've got these different numbers, and what these numbers signify is where are you sending them? So you can see 0.5 is going to be early intervention. So that might be in a regular mental health setting or a private practice office where the individual is saying, I'm really concerned about my drinking. It hasn't caused too many problems. Again, referencing sort of the diagnostic criteria from our last chapter, it hasn't caused too many problems. I can still work. I can still function. My family is still supporting me, but I need to make some different changes. And then you move to outpatient services. So this is a facility that an individual would go to receive treatment, but there's minimal oversight and minimal the individual's not living there. They go there maybe once or twice a week and they go for treatment. They usually maybe urinalysis or drug screening, and then they go home. Or maybe they go there for group therapy and urinalysis or drug screens and they go home. So intensive outpatient or partial hospitalization services. So if you ever hear anyone refer to a treatment setting as an IOP, that's what we're referring to. And this is still, so it's outpatient. So they don't live there. The clients don't live there. They still go home. They may still have a regular job, but that they are more involved with the agency. They're there on a regular basis, maybe even every day. But they are there's a lot of oversight on the individual. So the facility is doing urine drug screens. The facility is doing their individual sessions, their group setting. They may be doing some different other types of art therapy or other different, maybe even EMDR, other types of interventions or treatment approaches, but they're all being done at an outpatient setting, and the individual goes home. They do not live there. In sort of partial hospitalization, they may live there a couple of days a week, And then moving on to residential, folks live in the residential treatment facility. They live there. And these are usually long-term facilities, could be anywhere from 3 months, 4 months, 6 months, 9 months. I worked at one personally where folks lived in this treatment facility for beyond a year. So it wasn't uncommon for patients, or, well, there would never be called patients because it wasn't a hospital, but it wouldn't, where your clients would live there for 13, 14, 15 months. And that would not be uncommon. So they live there, and this is, you're referring clients to residential inpatient services when all of these other treatment approaches have not worked. They haven't had great success at these other approaches. So remember, we always start at the least and we move to the most intense or the most involved. Think of it again. So think of it as sort of a continuous flow. Did they start at the lower level and now have they relapsed and relapsed and relapsed, or the consequences keep piling up and piling up, and now you need to refer them to sort of more intense managed care. And so the inpatient can go from minimal oversight and involvement to great oversight and involvement, and you can kind of see that here, and that's why these, the point system is there. 3, 3.1, 3.3, 3.5. But these are all of residential services or inpatient services. The clients live there. They live there, and there's a lot of oversight. There's counselors, there's physicians, there's case managers, whatever it may be. And then, of course, moving to medically managed intensive outpatient services. These are the most monitored. These are folks who are on pretty significant levels of medication. Maybe they're medication to assist in sobriety, or maybe they're just psychiatric medications because they have pretty severe mental illness as a comorbid condition to their addictive use disorder. But again, and I want to reiterate this, the sort of this continuum of care and the ASAM criteria dictates based off of your diagnosis and your assessment and the history of the individual as it relates to their attempts at treatment or their attempts at sobriety, again, how they define sobriety. It starts with the lowest level of care and moves to the greatest level of care. So here's just the best example. It would not be appropriate for an individual to see you. Let's say you're at an agency setting and an individual comes to you and says, I've been drinking a lot. It's starting to cause problems at my job. It's causing problems at my home life. I don't feel very well about it. I want to make a change. My health is impacted by my drinking. I would like to make a change. It would be inappropriate for you to, and the individual has never sought treatment before, and you have no idea or thought, and no sort of verified by way of an assessment or a screening thought that they have another comorbid disorder. It would be inappropriate for you at that point to say, you need to go to 3. So we're looking at an inpatient treatment facility. It would be inappropriate for you to do that. It would be inappropriate for you to send this individual who has never had a history or experience with treatment to the highest level of care. You start at the lowest level of care. Now, if the individual has had a history of treatment facility stints and all of those, he's continued to relapse, he or she has continued to relapse, that's when you start looking at these different levels of care. I hope I'm making this clear because this is really, really, really important. I cannot tell you the amount of times that I've worked with clients who have, by virtue of case managers who don't know or follow ASAM criteria, or in one instance that I'm thinking about specifically, a judge who ordered a client who was going through a diversion program, ordered this client of mine to be in this inpatient treatment facility where he would live for 13, 14, 15 months. And this client had never had a history of treatment before. He had never attempted a lower level of care. by virtue of sending this client to an inpatient treatment facility, the client had to quit his job and had to move out from his family, which relied on him and his job for financial support. So, in advocating for our clients, I had to advocate for this individual to go to a lower level of care. And the case manager who worked in diversion, interestingly enough, really didn't want to hear my assertion backed up by the ASAM criteria, but ultimately we advocated for this client, and ultimately he was able to leave our treatment facility and was quite successful for quite a while after going through a lower level of care. I hope all of this makes sense. Of course, with everything else, just please call me and let me know if you've got questions or if you want to talk about this anymore. It's still really hard for me to do this online way of lecturing because I don't have the organic back and forth from you guys. But just let me know if you have any questions. All right, thanks.